Hello and welcome to this author interview, Conversations with Dr. Bauchner. I am Dr. Bauchner, Editor-in-Chief of JAMA, and I'm here with Tony Fauci, who at this point needs no introduction. Welcome, Tony.
Good to be with you, Howard.
Tony, so when I did the first live stream with you a few weeks ago, you mentioned this was almost like internship on every other night. You've now been at it for 2 months. What's it been like?
You know, it's the same, Howard. It's just, it's almost surrealistic. I've kind of figured I just have to suck it up. You know, sometimes you run on fumes, but like I made that allusion to the great reference point in our lives, our internships. It's almost beyond that, you know, but it's okay. You know, it's okay. You know, after a while, you adapt to it. You know, well, I made some mistakes early on. I just didn't sleep much, like 3 hours. Is no good. You can't do that too many days in a row. I forget to eat sometimes. That's not so good. So I got myself a little bit more reasonable now, where I get at least 5 hours of sleep a night. And I make sure I eat at least 1.5 meals a day. But it's crazy. I mean, it's literally a 20-hour a day job, but it's worth it, obviously. This is a historic challenge that we're going through from a public health standpoint.
So, Tony, I'll get to the big pictures and then some of the more detailed scientific questions, but I know I'd be remiss if not asking you this. And I've asked you this before, and you've had a very specific answer. You've dealt with 5 other presidents. This is your 6th. And President Trump, I think, looks at science a bit differently than scientists do and medicine people do. And, you know, he's given long press conferences. You've been there often. When he says things that are interesting to you, or you're thinking not consistent with how I think of science or medicine or clinical research, how do you process it, Tony?
Well, I mean, obviously, as a scientist, it's kind of tough when you hear things that don't fit in with the scientific method. But, you know, in fairness to him, after it's over, I get the opportunity to just go back and in a non-confrontative way, discuss it with him. You know, he has his own style. I mean, there are, you know, many people in the United States who like that style, the way he does things. But I can tell you, Howard, the one thing I have found to be absolutely clear is that he does listen. And for example, he may go out and express it in a different way, but at the end of the day, he takes very seriously what I and Dr. Birx and others tell him. So again, you know, it's just a difference in style. He's different than other presidents, but, you know, and other presidents are different from other presidents. It's just.
Well, I'm quite convinced the other day, you know, when he made his comments once again about chloroquine, if you hadn't been on the stage, I'm not sure he would have said, look, this is my feeling. I'm not a doctor. I think he could really understand that there's people who disagree with him. All right, so let's move on. As a country, what's become clearer and clearer over the last 2 weeks is the pandemic is affecting cities very, very differently. You have New York, you have Detroit, Chicago a bit. Boston really struggled. My own institution had to close for beds for a few hours over the weekend. In the high-intensity places, New York, Detroit, Boston, how is it, do you think those cities are doing?
You know, given the circumstances and the challenge that they have been thrust upon them, Howard, I think they're doing really very, very well. I think what people don't appreciate, unless you live through it, is what it means during that critical period when you transition from the linear to the exponential phase of an outbreak. You know, if you have the opportunity to be able to do containment before you have to essentially switch over to mitigation, and you have the capability, the resources, and the luck to be able to put it down before it exponentially expands, then you're going to be in good shape. But if you're in a situation like New York, where given a lot of aspects of the city, the dense population, you know, the subway system and things like that, and then all of a sudden you find that you're just playing catch up, you know, the way they handled it, you know, given the stress on them, I think was quite admirable. I mean, I think Governor Cuomo has done a really, really good job under amazingly difficult circumstances. Hopefully, and this is one of the things that we really feel that we need to stay ahead of, is as other metropolitan areas start to be getting challenged with the possibility of that exponential increase, that they implement the resources that they have to contain it. I think the mitigation that we're going through, the idea that we said the entire country should have a baseline level of following the guidelines of physical separation, even if they have not yet had a major spike, was really an important recommendation. And thank goodness, many locales have done that. And I think that's the reason why they're in good shape. In other words, to almost stay a step or two ahead. Don't wait until you get into the exponential phase to mitigate. Mitigate before you get there. And that's why I think what you're going to see, although I'm always very conservative in my cautious optimism, I think we're going to start to see soon, within the next week or so, kind of a plateauing out and a turning around. We got to be cautiously optimistic, not be overconfident, but I think we're going to start seeing that. The real challenge is if we do then try, which everybody's talking about now, to get back to some degree of normality, not turning a light switch on and off. That's not going to happen. But some degree of normality. We better make sure that we very aggressively and vigorously do not allow the resurgence of a case or 2 or 3 or 10 or 20 get out of hand. We've got to jump all over that so we don't have, recurrent peaks. Because if we do that, we're just going to be playing a sawtooth game instead of one and down, which is what we want to do.
Yeah, I was very proud of my profession, in part because of Governor Cuomo and other governors, when last week it really became clear that places were going to have to share ventilators, that you couldn't have some places that really had many ventilators saved for the exponential growth, whereas New York was suffering. I was very impressed with Seattle's donation back to other places. And I think that took longer than I had hoped, but I think at least from the ventilator standpoint, I have more faith that there's a sufficient number in the United States, depending upon what happens in the next week or two. Tony, do you think every metropolitan area is going to go from linear to exponential?
No, I don't think that's a foregone conclusion, Howard. I really think that you're going to start to see metropolitan areas who continue to really, really push this physical separation, that they do not necessarily have to do that at all. And that's my hope. I have in some respects, we got discouraged when we saw some videos of certain locations, not to be mentioned, where people were just frolicking in bars and in restaurants and on beaches. That was not good. I mean, they paid a price for that. I think we're getting it now, and people realize that, the sacrifice that you do from disrupting very severely your normal social interaction is going to pay off in a very positive way in the end. So the short answer to your question, Howard, is I don't think it's absolutely necessary that we're going to see spikes in every metropolitan area.
Now, as you know, a number of journals, including JAMA, published some papers almost 5 or 6 weeks ago about asymptomatic spread. The data were limited, but it was clear that there was a fair number of scientific reports that it was occurring. And then obviously the CDC's change on masks the past few days. I was surprised it took 4 or 5 weeks for the CDC to make that change. I recognize there was concerns about shortages of masks, although clearly people have become very creative in how they're doing it. Can you talk a little bit about the change and the importance of this mask wearing that the CDC has recommended?
Yeah, that's a really good question. That delay, Howard, was driven by exactly what you said, was we were being driven by two opposing forces, a lot of information coming in that people who really needed masks, the healthcare workers who are putting their lives on the line every day, were saying we don't have enough PPE, including masks.
Right.
And then the possibility that we're saying we want more broad community use of masks. But now the idea of being creative and fashioning masks in a way that you don't take away from the N95 and the other surgical masks that people need, I think is a good thing. It's a good thing for several reasons. When people are trying to get out into society and gradually stepping towards normality, even though masks are not perfect, and I spend time at the task force meetings repeating, saying, don't let the perfect be the enemy of the good. You know, you don't want 100% protective. The mask generally is used, I mean, it's used for two reasons, but one of the most prevailing reason is if you do not know that you are infected, wearing a mask will go a long way to prevent you from infecting somebody else. You know, it's not 100% in protecting you, but it's certainly if you wear a mask and someone else wears a mask in a situation where you really cannot guarantee that you can maintain a 6-foot distance, I think that would be quite contributory to the decrease in spread, not to mention, you know, the alleviation of some anxiety on the people. You don't want to have false confidence, but I think it goes a long way. We're having debates about how aggressively we might want to implement that. One of the things that we're trying to do is to maybe test those masks. You know, the Hanes company that makes underwear and other things,
right,
is able to really crack out, you know, millions of masks. And if we can get that out and show by some simple experiments the ability or not to trap virus in droplets in that, we may be able to get that more widely distributed. I, for one, am in favor of that. I think that's something we should be doing.
Well, it's interesting. You know, hindsight is always helpful, but, you know, I think the reason New York, Paris, and London have so struggled is they have robust metros and underground subways, and they probably had perfect vector, subway, asymptomatic spread. Those three cities have really struggled. Now there's exceptions, Tokyo, Berlin, but those three cities have really, really struggled the last few weeks.
That's for sure.
Tony, I think what I read yesterday, you know, 270 different randomized trials, 300 different randomized trials, 50 different agents. Anything new that you've read or has crossed your desk or still too soon about any of the results from clinical trials?
Yeah, it's all still too soon, Howard. You know, I think what we might start seeing is that when randomized control trials, actually start getting results, you know, we all like to see a positive result, but one of the advantages of doing a randomized trial is that if you find something that doesn't work, just get it off the table quickly,
right? You
know, and move on to the next one. And that's the reason why, as much as I completely understand that, you know, because, you know, I've been through this before many years ago during the early years of HIV, when you had no therapy at all, there was the tension between doing a trial and essentially just giving something to someone. It becomes easy to do when you have a drug that's approved for another indication, because you can do an off-label use. But I would hope that off-label uses don't prevent us from continuing to do the randomized controlled trials. We have to do them. So far, in short answer to your question, Howard, no results yet on anything, but it will be soon, as you'll know, as you see papers coming in. Right. It will be soon.
I mean, I think the other thing most of our listeners recognize, a successful clinical trial will reduce mortality, say it's in the intensive care unit, by 20%. But that's a number needed to treat a 5 or 10 or 15 or 20. It's not going to cure the disease.
Right.
And so I think people need to be prepared. There may be successful trials, but it's not going to be a dramatic reduction in mortality. That would be surprising.
It would surprise me greatly. It really would. It really would. You know, the thing that's interesting that, you know, obviously relates a bit to therapeutic intervention, Howard, is that the pathogenesis of this disease just fascinates me. I mean, I don't have a lot of time to look up at the ceiling at night because I don't sleep that much. But the thing, as a person whose research career has been focused on the pathogenic mechanisms of HIV disease, you know, the idea that you can have somebody who is sitting down, getting in his office, then feeling sick, getting febrile, go home, and febrile for 5, 6, 7 days. And then all of a sudden, they crash. And they crash over a few hours. They go from feeling okay but febrile and achy to all of a sudden having difficulty breathing. Oxax goes down, tachypnea, bingo. They have infiltrates and they get intubated. So what the mechanism of that is, we looked at some autopsy cases, something that even looks a little bit like DIC as opposed to inflammatory infiltrate. I have to be humble and say, I don't know what's going on there, but boy, we need to find that out, because unless you know what the pathogenic mechanism is, it's going to be tough to do intervention.
Yeah, there's been tremendous speculation both about that and the lack of infection, symptomatic infection in children. They may be asymptomatic carriers, but they're clearly not particularly symptomatic. Greg Poland was on a week or so ago, Tony, and I know he's a vaccinologist who really is very schooled in the different types of vaccines. He wasn't certain we were trying to develop the correct vaccine, that there were different elements to attack. Could you comment on that?
I'm not sure what he meant, Howard. Was he a little bit more specific about that?
Yeah, he said current vaccine candidate is the S protein, drives Th2 response, and he was wondering if it should be the SM protein. I'm not sure about the specifics beyond that. Are there different types of vaccines being tried?
Yes, but they're mostly different platforms. I think they're all going for the same spike protein. Depending upon the platform that you're in, you may get more of a T cell response or more of an antibody response. So there are a few going on. The one we have is an mRNA one that's coming out of NIH, but there are other potentially good ones that are already starting in clinical trials. The bottom line is we do not know what the correlate of immunity is. You can do animal model studies, but we don't have a good animal model yet. But we do know that certainly antibody responses are the things that are the critical endpoint that we say. That's always the case with vaccines. You always have a pretty clear cut because you take a look at what the relative titer of a neutralizing antibody is compared to the response. It's a little bit more difficult to measure T cell responses and what role they have in the control of infection. So, Greg's got a point. There are different approaches. I think we're just going to have to see how it works out with the vaccines that we have. But the good thing is we got a bunch of candidates using different platforms. mRNA, DNA, proteins, viral vectors, clearly good viral vectors.
Convalescent plasma serology has surfaced. We had published a small case series, 100-year time-honored approach to treatment. And it's a combination both as a therapy in terms of convalescent plasma, but large serology studies will give us more information about incidence and prevalence.
Right.
Do you have any sense of what's going to happen with either it as therapy or as markers for people who've been infected and haven't been infected? Can you see that playing a role as we try to get back to normalcy?
Okay. So actually two questions there.
Right. So that's right.
So let me take them separately.
Okay.
The idea about convalescent plasma or even hyperimmune IG is clearly a lot of enthusiasm. We have decades, if not a century or more.
Right.
That's the birth of infectious diseases in immunology, as you know, how it comes from passive transfer of antibodies. So that's at least a good approach that's worth going. And trials are underway. Hopefully, we'll get some data soon on that. It might be a good way of therapy. The idea about serology and serosurveillance is going to play a major role in doing a framework for getting back to normal. I was spent until the wee hours last night in the Roosevelt Room of the West Wing of the White House with my colleagues on the task force, trying to integrate the public health issues into the practicality of after 30 days, the extension of the guidelines for 30 days till the end of April, what are the kind of things you have to have in place to safely and carefully march towards some sort of normality? And clearly one of the things is to get a feel for what the penetrance of infection was and who out there has been infected, recovered, and is now not vulnerable. Because those are the people that when you put them back to particularly critical infrastructure jobs, that you worry less about them driving an outbreak than those who, in fact, are antibody negative and very likely have never been exposed. So you really want to get a good feel from a countrywide where we are, and specifically in different areas, different districts, different cities. The way we're going to do that is, first of all, we got to get, and we do have antibody tests that can quickly be done, cheaply get a result right away. But we got to validate them first. And the reason is there have been some unfortunate international experience where certain countries, no naming who they are, I don't want to embarrass them, have ordered millions of these antibody tests from another country only to find that they don't work. So when you hear us talking about having to validate these tests, that's absolutely critical. Otherwise, you'll go down a path that will be very misleading.
Yeah, it would seem like in this, hopefully this march to normalcy, understanding who's been infected and who hasn't will be critically important. Tony, based upon previous coronavirus outbreaks, what's the assumption about how long immunity will last if someone's been infected?
You know, it hasn't been looked at as carefully as we would have liked now to have looked at it. But the way, you know, Howard, when you get into a situation like this, as you and I have said so many times, you got to act on evidence-based. But sometimes when you don't have the real-time evidence, you got to act on historical-based. And generally we know with infections like this that at least for a reasonable period of time, you're going to have antibody levels that'll be protected. Now, the problem is that, you know, there were about six coronaviruses that were out there that are responsible for, you know, 10, 15 to 30% of the common colds that we see. So if a person gets infected with coronavirus A and then gets reinfected with the coronavirus, it may be coronavirus B. But right now, we don't think that this is mutating to the point of being very different. So we're making an assumption, which I think is a reasonable assumption, that this virus is not changing very much. And if we get infected in February and March and recover, that next September, October, that the person who's infected, I believe, is going to be protected. We don't know 100% for sure, but I think that's a reasonable assumption.
Right. That was actually my next question, Tony, because you see a lot more data than virtually anyone in the world. I assume some laboratories do. Has there been any evidence about mutation in the virus?
Yeah, well, it's an RNA virus, so it's going to mutation.
All right.
Whether or not mutations are functionally relevant in the sense of changing any recognized function, transmissibility, virulence, or whatever, there's no evidence of that right now.
Now, just before you came on, Josh Sharfstein and I released an editorial that called for a huge investment in the public health service, that we don't really have the capacity at the moment to test, track, trace, and quarantine. We recommended medical students, that's less critical. Do we need a huge investment in the public health service? Tony, how do we get back to normalcy where we can identify cases as they develop and isolate those individuals so we don't have to go back to social distancing?
You know, that's a great question and a great point, Howard, because even when I was in medical school, my phenomenal mentors like Walsh McDermott and some of the giants in public health, when I was at Cornell Medical School, were telling me that the public health infrastructure in the country, because we've done so well in containing infectious diseases, has had the perverse effect of diminishing the capabilities of the local public health infrastructure in the country. And it hasn't gotten any better. It's actually got a little bit worse as you go along. And because we're so good at what we do, and we have vaccines and we have therapeutics, and we've handled outbreaks reasonably well. We've let it slip. Boy, if this should be a lesson for the future, I hope that when we get out of this, which we will, that we do take a really good look at the long-term investments in the future for the public health infrastructure and the public health service itself, but mostly the state and local public health, because we have a habit of when we get over a challenge, we say, okay, let's move on to the current problem. Something like this, we should never, ever be in a position of getting hit like this and have to scramble to respond again. I mean, this is historic. I mean, we've all learned in the history, going back to what happened in 1918. Well, we didn't have hardly any of the interventions or the capabilities that we have now. And still, when you see what happened and is happening to New York City, that is beyond sobering. That's really terrible.
Now, Tony, I looked up old data last night, in part preparation for this, but also because I get so many opinion pieces to read, and people talk about this being the worst pandemic in modern American history. I do recall HIV/AIDS. And at the peak years, about 30,000 or 35,000 people died a year for 3 or 4 years. How do you contrast this with what you lived through during HIV/AIDS?
There are some similarities, Howard, but there are some really serious differences. And, you remember, I got involved with HIV like a week after the MMWR came out in June of 1981. I completely turned my lab around and started admitting patients with a disease with no name, no etiology, and we didn't know what we were doing. During those early years, it was really insidious, and it seemed to, even though we found out later it didn't, involve a very circumscribed demographic group. So although there was a lot of talk about it, it didn't instill fear globally in anyone for a while. It was cumulative, and only when we found out through the antibody test that what we were seeing with ill patients was the tip of the iceberg did people realize that this was turning into a global problem that would extend over 4 decades. And at the end of the day, almost certainly will kill infinitely more people than this coronavirus will. However, with this, it gets truncated into weeks and it explodes, and everybody's vulnerable and everybody's afraid. And it's all over the world in real time, very obvious. Where with HIV, it was insidious and ultimately turned out to be historic in its implications, whereas here it just was exploded right in front of our face. So that's the similarity and the difference. They're both, very serious public health challenges, but they're so different in how they've presented themselves to society.
Keys to the next few months, Tony. I've talked about the fall being a critical time. I like you am optimistic. I have incredible faith in the American healthcare system for certain aspects of the type of care they provide. And we do intensive care well. We've learned to share. Healthcare workers have been just extraordinary. I think we will manage over the next few months, but I worry about the fall. Vacations will end. We'll have gotten back to some normalcy, but you want people to go back to school. You want people to go back to college. You want business to resume. What are the keys to the next 3, 4, 5 months?
Yeah, the keys are to make sure that we have in place the things that were not in place in January, that we have the capability of mobilizing identification, testing, identification, isolation, contact tracing. There will be cases, Howard. From everything we know about this virus, it's not going to disappear from the planet for sure, given what we know how globally distributed it is. So there will be cases. We've got to be able to act on them in a very deliberate way that doesn't allow us to get into the situation we find ourselves right now. Ultimately, the answer is going to be a vaccine. But that will be important as we get into a cycle type phenomenon. But your point is so well taken, because this fall, Howard, is going to be that bridge between the acute chaos, as it was, that we said, I don't mean chaos, that people aren't responding well, but the intensity of what we're doing now, it's almost certainly going to go down a bit. And then when the fall comes back, if we get back to some form of normality, we've got to be careful we don't ever let it get out of hand again. People ask me, are things that never going to change? I think the idea of simple things that we didn't take seriously before, constant hand washing. When people have fevers, keep them out of places where they can spread. Do not send a sick child to school. Do not send a sick worker into the workplace. Don't anybody ever shake hands again. I mean, it sounds crazy, but that's the way it's really got to be until we get to a point where we know that the population is protected.
Have you seen any data? Last question, and then I'll finish with a personal observation. Have you seen any data yet, Tony, that encourages you that vaccines will be sooner than you had predicted before? You've been much more reticent to say we're going to have a vaccine in 3 months, 6 months, or 9 months. And you've been through this more than virtually anyone in the United States. Any sense of timing of vaccine? Okay,
but let me explain. Yes, but let me explain the two factors that will determine that, Howard. Mm-hmm. In any vaccine, the candidates that I've spoken about, or the 2 or 3 others that are out there that will likely be as good or better, who knows, is that one of the things you got to be careful of when you're dealing with the coronavirus is the possibility of enhancement. So we need to, as we're going through the phase 1 trial, we're now going to the third part of the phase 1 trial, the highest dose. There were 3 doses, 25, 100, 250. We're in the last one right now, is to do animal studies to show that, and we likely mice studies and then graduate to non-human primates, to show that when you have an animal that's vaccinated and you challenge them, that you don't get the perverse effect of enhancement. You've got to do that. And then you go into phase 2. So the first one is show you don't get enhancement.
Oh.
Hello?
Hi, Tony?
No, this is Mike Levitt. I've just been waiting and wondering if this was going to happen.
Oh, it is happening, Mike, but you've interfered with a different podcast. So we have to go back.
Okay, so I'll just wait until somebody calls me.
Yeah, we'll call you. Sorry.
Thank you.
Can you get it back?
I'm watching. Howard,
we're back.
Okay, sorry. So I'm sorry about that. I don't know what happened, but
my fault. Go ahead, Tony. So you're talking about the vaccines.
So with the vaccines, the first is to show there's no enhancement. The second is when we get into phase 2, we have vaccine sites all over the world. If you can show early on that there's efficacy in a phase 2 trial, and it really looks encouraging, you can get the FDA to give you almost an emergency use authorization to start using it before the 18-month period that I said. You see? So 2 things. A, make sure it doesn't cause enhancement. And B, if there are enough cases while we're doing the phase 2, you can get good efficacy data from a phase 2 if it's properly powered.
So, Tony, I want to end. I know you have another call. I just want to read something that someone sent me. Lots of love. Thank you, Dr. Fauci. You have been a wonderful, level-headed, and well-spoken leader in this fight, and you're very appreciated. I have said repeatedly, both publicly and privately, if there's a Mount Rushmore of the NIH, you're the first member. And I want to show you something someone showed me this morning, sent it to me. It was in my mailbox. I thought it would be very, very amusing. And Tony, I hope you're collecting all the wonderful cartoons about you. There are many of them are on my desk. There's so many nice, funny cartoons about you.
Howard, it's very interesting. That would be nice if I could, but I don't even read them because I have so many other things to read. People tell me like you do, hey, look at this, look at that. Maybe someday when this is over, I'll sit down and read about it. But thank you for saying that. But one of the things that I get a little embarrassed about, obviously it's nice to see things like that. But the real thing we need to keep shouting out for are the healthcare workers who are out there doing it.
They are heroes. They are heroes. They are heroes.
Without a doubt.
Tony, again in 2 or 3 weeks, if you have time, stay healthy, stay well, get some sleep.
Look forward to seeing you again soon, Howard. Take care.
Bye, Tony.
Take care.